Greetings from Minnesota. My name is MarkJelinek, and this is my surveillance presentation. Let me go ahead and open this up, share my screen. Click this so you don't have to look at me. Let's go ahead and start. So my surveillance presentation focused on infant mortality, specifically neonatal infant mortality. Background. Infant mortality is the death of an infant before his or her first birthday. The infant mortality rate is the number of infant deaths for every 1,000 live births. In addition to giving us key information about maternal and infant health, the infant mortality rate is an important marker of the overall health of a society. The leading causes of infant death in the U.S. are birth defects, disorders related to premature birth and low birth weight, sudden infant death syndrome, conditions due to pregnancy complications, and injury. Infant mortality includes perinatal mortality, which is death when less than 7 days old, neonatal mortality, death in the first 27 days of life, and postneonatal mortality, death from the infant's 28th day within the first year. Due to data availability, this surveillance focuses specifically on neonatal mortality. Minnesota infant mortality rates are lower than the national average. There has been a general downward trend in the overall infant mortality rate in Minnesota. However, there are striking disparities in these outcomes for certain populations in Minnesota. In Minnesota, babies born to younger and older mothers have a higher rate of infant mortality. Also in Minnesota, American Indians and Black people have higher rates of infant mortality than other racial and ethnic groups. Risk factors. Factors that affected the risk of infant mortality for single-born infants included birth weight, race, sex, gestation, birth order, maternal age, and education and prenatal care. The most important predictor for infant survival was birth weight, with improved survival for both Blacks and whites associated with increased birth weights. Overall, nationally, Black infants had twice the mortality risk of white infants. The higher risk for Blacks was related to higher prevalence of low birth weight and to higher mortality risk in both the neonatal and postneonatal periods. Other risk factors include smoking, drug and alcohol abuse, poor diet, stress, lack of prenatal care, and chronic illness and other medical problems. Surveillance questions and their significance. My questions are: what counties in Minnesota have the highest neonatal infant mortality for 2006-2010? Are there major fluctuations over 5-year blocks of time in neonatal infant mortality? And is there an economic component? And is there a relationship between the economic health of the counties and neonatal infant mortality? Infant mortality is an important marker for the health of a society. It can be used to influence public health prevention actions, interventions, and policymakers. Additionally, it can help to identify at-risk populations and also be used to evaluate the effectiveness of existing and new prevention programs. Since infant mortality is an important marker for the health of a society, it would be helpful to know which counties have the highest infant mortality and if this is consistent over time. The first and second questions focus on this. As stated earlier, there are striking disparities in infant mortality for certain populations in Minnesota. American Indians and Black people have higher rates of infant mortality than other racial and ethnic groups. Evidence indicates that racial and ethnic differences in morbidity and mortality are tied to socioeconomic resources. It's important to understand how socioeconomic status relates to health disparities. Socioeconomic differences in health outcomes have been widely documented for most health conditions in most countries. People who are poor and who have less education are more likely to suffer from diseases, to experience loss of functioning, to be cognitively and physically impaired, and to experience higher mortality rates. As such, it would be interesting to see if there's a relationship between the economic health of a county shown by per capita income and infant mortality. Data sources, collection system, and quality. The infant mortality data was taken from CDC's Environmental Public Health Tracking Network. CDC provides funds for 26 state and local health departments to develop local tracking programs. Grantees submit data to the National Tracking Network and host their own data and information on their own websites. The data for Minnesota came from the Minnesota Tracking Program, which is part of the CDC's National Environmental Public Health Tracking Program. The data sources for the reproductive and birth outcomes measures for the reports are birth and death certificates and fetal death reports filed with the Minnesota Department of Health Office of the Vital Records. The quality of infant mortality data presented in the report is not complete and exact. In looking at the data for infant mortality, many of the counties had suppressed data. This is data that is not available to protect individual privacy. Typically, reproductive and birth outcome counts from 1 to 5 are suppressed. Additionally, some of the data is listed as unstable. Rates based on counts of 20 or under should be interpreted with caution. The rate is marked unstable because it can change dramatically with the addition or subtraction of one case. In order to have enough data to run the surveillance, I looked specifically at neonatal mortality. Additionally, I had to look at smooth data. Smoothing borrows information from neighboring areas to stabilize results from sparsely populated areas. Smoothing is used to reduce variability in the data, allowing for patterns to emerge. In order to determine the economic health of a county, I looked at per capita income of the counties. This data was more exact and complete. The data was found in a Wikipedia article, but ultimately it came from the 2010 United States Census data and the 2006-2010 American Community Survey 5-year estimates. Analysis. Question 1, there was no analysis. I only ran the report infant mortality, smooth, average annual neonatal mortality rate per 1,000 live births over 5 years for 2006-2010. Question 2, I ran 2 more neonatal reports for the years 2001 and 2005, 2011, 2015. All 3 reports were compared to determine if there were any major fluctuations of rates. 2 counties could have the same average. However, if one had more variability, I needed a way to look at that. So for the comparison analysis, I looked at each county over the 3 time periods, took the total sum of squares, and then took the square root of that to look at the variability around the mean. I also performed the Grubbs outlier test of the square root of the total sum of squares to see if there was any outliers, to see if any of the counties had any major fluctuations. Question 3 compared the 2006-2010 neonatal report and 2006-2010 county list of per capita income. I ran a linear regression and tested correlation using Pearson's test. Results. What counties in Minnesota have the highest neonatal infant mortality for 2006-2010? Minnesota has a total of 87 counties. The report showed the counties with the highest average annual infant mortality rate for neonatal were Norman, 5.21 rate, Big Stone, Monoman, Clay, and Traverse. The lowest county was Grant with a rate of 1.91. The outcomes for Cook and Kittson counties were both suppressed, so they were not used. The outcomes for Lac-Qui Pearl and Red Lake were both listed as unstable, although those were used. Are there major fluctuations over 5-year blocks of time? The county with the highest fluctuation around the mean is Grant, had a mean of 3.25 and a total sum of squares for the 3 time blocks of 3.39 and a square root of the total sum of squares of 1.84. The county with the lowest fluctuation around the mean was Scott, had a mean of 3.28 and a total sum of squares for the 3 time blocks of 0.005 and the square root of the total sum of squares of 0.07. This shows that the highest fluctuation was 1.84 around the mean per 1,000 live births for 5 years. That's less than 1%, which would not be classified as a major fluctuation. The Grubbs outlier test also showed there were no outliers at a 5% level of significance. It had a p-value of 0.512, so there were no outliers. The infant neonatal mortality rate is relatively consistent for the counties over the time period. Big Stone, Cook, Kittson, Red Lake counties were not used because they had values that were suppressed. Lac-Qui Pearl was used, but its rates were unstable. Is there an economic component, and is there a relationship between the economic health of the counties and neonatal infant mortality? The linear regression had a R-squared value of 0.65% and a Pearson correlation p-value of 0.462. This does not indicate a relationship between the economic health of the counties and infant mortality. Below you can see the regression analysis with the R-squared of 0.65%. Here's a fitted line plot, which obviously does not show correlation. And the correlation, the Pearson coefficient p-value had a 0.462. For the analysis, I removed Cook and Kittson counties because the values were suppressed. The values for Lac Qui Pearl and Red Lake were used but were unstable. Limitations. The biggest limitation is the accuracy and completeness of the data. In many counties, the data is suppressed or unstable. For the most complete data set, the report focused on neonatal mortality during the years 2006-2010 using smooth data. The fact that the data was smooth was a limitation. Smoothing borrows information from neighboring areas to stabilize results from sparsely populated areas. Smoothing is used to reduce variability in the data, allowing for patterns to emerge. I look specifically at neonatal mortality because of the data. A fuller understanding of infant mortality by also looking at post-neonatal mortality and perinatal mortality would give a more complete picture of infant mortality. The per capita income for a county may not be the best indicator of economic health of a community. Additionally, there still may be a relationship between income and mortality, but the surveillance was not specific enough. Conclusions and next steps. The surveillance showed that for 2006-2010, the counties with the highest neonatal mortality rate were Norman, Big Stone, Monoman, Clay, and Traverse. These are counties the state may want to focus on in reducing neonatal mortality. The surveillance showed that for 3 5-year blocks of time between 2001-2015, the rate was relatively consistent without any major fluctuations. No relationship was shown between the economic health of a county, shown by per capita income, and the neonatal mortality rate. Again, does not mean there isn't a relationship between income and birth mortality, just that per capita income at the county level did not show it. In Minnesota, looking at infant mortality is difficult because of the lack of easily obtainable data. Much of the data is suppressed. Next steps. Surveillance, postnatal mortality, and prenatal mortality to get a fuller understanding of infant mortality. Since much of the data is suppressed or unstable, look at sampling methods to predict values for counties, or see if there's a way to get access to the suppressed data through the state. See if there's a socioeconomic relationship to infant mortality. Look at the income level at the individual level. At the individual level, one could also look at potentially associated predictors like health, diet, tobacco, alcohol, drug use, and the use of pre-birth medical services. Acknowledgements and references. So here's my acknowledgements and references. A big thank you for a paper I found that related socioeconomic status to race and ethnicity. That's my presentation. Thank you so much for letting me present. And, oh, I have to stop.